Hello everyone. Now we'll discuss about subfacial endoscopic perforator surgery. It is a 2024 question. I have also covered about detailed in varicose vein in another video which I'll be uploading soon. Coming to the venous system of the lower limb, it has three main components: the superficial, deep, and the perforator system. The superficial system above the deep fascia, it consists of the great saphenous vein, which is present in the medial aspect, extends from ankle to SFJ. It has 10 to 12 tributaries. The small saphenous vein is posterior to the calf muscle. The deep system exists below the deep fascia. Major connules are from the anterior or the posterior tibial, peroneal, popliteal, femoral, and the profunda femoris veins. Reservoirs are the soleal sinusoids and gastrocnemius veins. Perforator veins, they connect the superficial and the deep venous system. Blood flow is only from superficial to deep. The walls prevent the retrograde flow. The perforators are 50 to 20 named and around 200 unnamed perforators exist. Varicose veins are permanently elongated, dilated, and tortuous superficial veins with pathological reflex from incompetent venous valves. The varicose veins classification. First classification is based according to the venous system involved: the GSV varicosity, the SSV varicosity, the perforator incompetence, the blowouts. The classification 2 is according to the size: the thread veins, the reticular veins, and the varicose vein. The thread veins are the spider veins or the telangiectasias. Diameter is 0.5 to 1 mm. Dilated or purple dermal veins, usually around the ankle, common in females. Reticular veins are 1 to 3 mm in diameter, localized to the subcutaneous tissue, slightly larger than the thread veins. The varicose veins, the diameter is more than or equal to 3 mm. Dilated, elongated, tortuous superficial veins. Measurement is to be taken in the standing position. The blowout mechanism for the perforator veins. In normal state, the calf pumps empties soleal sinusoids. Ambulatory venous pressure drops from 90 to 25 mm of mercury. The perforator diameter is 0.5 to 2 mm. 1 to 2 bicuspid valves are present. In incompetent state, that is the blowout state, the pathological dilatation of more than 3 to 0.5 mm diameter of the superficial vein occurs. Outward flow duration is more than 0.5 seconds. High deep venous pressure is transmitted directly to the superficial veins and gator area microcirculation. Histology: smooth muscle hypertrophy, collagen deposition, and valve fibrosis are noted. Pathophysiology can be mainly explained by the fibrin cuff theory, white cell trapping theory, and the ambulatory venous hypertension. The fibrin cuff theory: incompetence of the venous walls leads to stasis of blood, which produces chronic ambulatory venous hypertension, which causes defective microcirculation. RBCs diffuse into the tissue planes. There is lysis of RB, release of hemosiderin, which leads to pigmentation. Further causes dermatitis, capillary endothelial damage. Prevention of diffusion and exchange of nutrients causes severe anoxia and chronic venous ulceration. The white cell trapping theory or the leukocyte hypothesis: during venous stasis, leukocytes become activated. They adhere to the endothelial cells. They release proteolytic enzyme, oxygen-free radicals, inflammatory mediators. This results in endothelial injury, microcirculatory damage, lipodermatosclerosis, venous ulceration. The ambulatory venous hypertension. The venous hypertension causes elevated ambulatory pressure transmitted to the gator skin. There is capillary distension. Pericapillary fibrin cuffing occurs, which causes brows and the Bernard hypothesis. Leukocyte trapping. The WBCs are trapped in the distended capillaries, which lead to migration and activation, which causes release of proteases and free radicals. The endothelial damage. Inflammatory mediators increase permeability, causing severe edema. In dermal fibrosis, the fibrin and the inflammatory products create lipodermatosclerosis. Skin becomes hard, indurated, and brown. In tissue hypoxia, poor oxygen delivery to fibrotic skin causes atrophy blanche, and in ulceration, minor trauma or the spontaneous breakdown of the hypoxic epidermis occurs leading to ulceration. The three main mechanisms of the venous hypertension. First one is the reflex. In 70% of the cases, there is retrograde venous flow, which causes superficial GSV or the SSV incompetence, post-thrombotic syndrome, primary valve failure, or perforator incompetence. Second is the obstruction, which is noted in 30% cases. There is impaired venous outflow. The cause is the post-thrombotic scarring or occlusion. May-Turner syndrome, that is the iliac vein compression, pelvic veins, pelvic tumors, and congenital webs are the causes. The clinical note is if iliac obstruction is dominant, venoplasty or stenting may precede sepsis. In calf pump failure, the reduced muscle pump mechanics, the cause is ankle joint ankylosis, neurological deficits, immobility, and obesity. Exacerbates the existing reflex or the obstruction. The clinical classification, this is very important even for practicals. The SEPS classification, the C0, no signs of the venous disease. C1 is telangiectasia or the radicular vein. C2 is varicose vein. C3 is edema. C4A pigmentation or eczema. C4B is LDS or atrophic blanche. LDS is the lipodermatosclerosis. C4C is the chronophlebitis. C5 is the healed venous ulcer. C6 is the active venous ulcer. This has further characterized as symptomatic S, asymptomatic A, and recurrent by R. For etiology, we use EC, congenital, EP, primary, ES, secondary, that is post-thrombotic, and EN, no venous cause identified. For anatomical classification, we use AS, superficial veins, AP, perforator, AD, deep veins, AN, no venous location identified. For pathological classification, PR is reflex, P0 is obstruction, PR0 is reflex and obstruction, PN is no venopathophysiology identifiable. This chart need not be mentioned, but I added it for the purpose of knowledge for practicals, as it is one of my professor's favorite Viva question during case presentation. That is the differential diagnosis of the lower limb ulcers. For venous, the site is gator zone, medial more than lateral, arterial, pressure points the heels, toes, and the malleoli. Neuropathic, pressure points the metatarsal heads or the heel. Margins for venous, they are irregular sloping. Arterial have punched out and well defined. Neuropathic have punched out edges. The base for venous is formed by the granulation tissue, fibrin slough. Arterial, it is pale, necrotic, and grey. For neuropathic, granulation present and may be deep. Surrounding skin, lipodermatosclerosis, pigmentation, edema. Arterial, pale, cold, thin, hairless, and shiny skin is noted. In neuropathic, the skin has peripheral neuropathy signs and Charcot changes. The pain in venous, it is mild to moderate and worsens on standing. In arterial, there is severe or worse night pain or pain on the limb elevation. Neuropathic is usually painless. Depth, the venous is superficial to medium. Arterial is deep to tendon or bone. Neuropathic may reach the bone. The various modalities of treatment of varicose veins are as follows. It is conservative, minimally invasive, open method, and adjunctive method. In conservative, we have lifestyle changes, compression, Una boot, and oral medications. In minimally invasive, we have ablative methods, the endothermal methods, and the non-endothermal methods. In endothermal methods, we have EVLA, endovascular laser ablation, RFA, radiofrequency ablation. In non-endothermal, we have the sclerotherapy and the mechanico-chemical ablation, the cyanoacrylate glue therapy, pilonidal endovenous microfoam therapy. The open methods are the superficial vein surgery, that is the Trendelenburg procedure, the deep venous valve reconstruction, the stenting, and the perforator surgeries. In adjunctive therapies, we have the telangiectasia and reticular veins are treated by sclerotherapy and transdermal laser treatments, and the perforator veins are treated by stab avulsion, subfacial ligation, linto-vertical approach, SEPS, and transillumination. Now we'll further discuss about SEPS in detail. SEPS, the subfacial endoscopic perforator surgery. Subfacial endoscopic perforator surgeries is a minimally invasive endoscopic procedure designed to treat severe chronic venous insufficiency, particularly when it is driven by incompetent perforating veins in the lower leg. By replacing the historical highly morbid open Linton operation, SEPS minimizes the risk of severe wound complication by placing incisions away from compromised ulcerated skin. The core objectives and pathophysiology of the procedure. The primary goal of SEPS is to interrupt the transmission of high pressure deep venous reflex into the superficial venous system during calf muscle contraction. The target is the incompetent perforator veins, typically cocked perforators in the medial calf that fail to prevent the retrograde flow. Indications and contraindications of SEPS. The strong indications are the active venous ulcer C6 resistant to 3 to 6 months of the compression treatment, recurrent venous ulcer C6R with proven perforator incompetence, healed C5 for recurrence prevention, severe lipodermatosclerosis C4B, symptomatic incompetence. The absolute contraindications are active cellulitis at the operative site must treat with antibiotics 2 to 4 weeks prior, acute DVT within 3 months, critical arterial ischemia, ankle brachial plexus index of less than 0.5, no demonstrable perforator incompetence on duplex. SEPS alone does not treat superficial reflex. Concurrent or stage saphenous ablation, EVLO or RFA is required in GSV or SSV incompetence if present for best healing rates. Operative setup, anesthesia, positioning and the equipment. The patient positioning, supine, slight Trendelenburg, 5 to 10 degrees. Operative leg is semi-flexed at knee and elevated to 20 to 30 degrees. Eschmark bandage or thigh tourniquet is inflated to systolic at 100 mm of the mercury to exsanguate the limb and improve visualization. Anesthesia and preparation. General anesthesia is preferred. Low molecular weight heparin should be administered preoperatively with single dose of the cephalosporin. Skin preparation should be done from groin to toes. The standard SEPS equipment: 30 degrees angle telescope, 5 mm or the 10 mm size is needed for visualization. Carbon dioxide insufflator maintaining 25 to 30 mm mercury subfacial pressure is required. Ultrasonic dissector or the ligashore or the 5 mm clip applicator for hemostasis is required. Portable intraoperative duplex ultrasound for real-time localization is needed. Surgical technique and the spatial setup. The procedure is executed under general, regional or local tumescent anesthesia, typically using a two-port technique. First, the port placement. Small incisions of 1 to 2 centimeters are made in proximal unaffected segment of the medial calf, well above the zone of lipodermatosclerosis or active ulceration. Second step is the space creation. A deep fascia is incised and a subfacial plane is developed between the muscular compartment and the overlying fascia. This optical space is maintained either via mechanical balloon dissection or more commonly through carbon dioxide gas insufflation maintained at a pressure of 10 to 15 mm of mercury. Endoscopic visualization. A 30-degree laparoscope is introduced alongside a secondary working port to navigate the subfacial space. Dissection and interruption. Perforating veins traversing the subfacial space are identified, skeletonized and occluded. This is typically achieved using endoclips and ultrasonic or bipolar coagulation followed by division of the vessel. The image illustrates the Port placement. The 10 mm endoscope port placement on the medial calf and distal 5 mm or the 10 mm post placed posterior-medially for the working ports. Step 1. The exsanguination done by applying the eschar bandage to reduce blood in the subfacial space crucial to endoscopic visualization. The step 2. The fasciotomy, and port 1 is introduced to the same incision, 1 to 1.5 centimeters longitudinal incision in the healthy skin, blunt dissection through fat, 1 centimeter horizontal deep crural facial incision is given. Step 3 is space creation. Insert the initial trocar used for carbon dioxide inflation to 25 to 30 mm of mercury or balloon dissection to separate deep fascia from the underlying muscle. Step 4 is the triangulation setup. Insert the second working trocar 3 to 5 centimeters distally under direct vision. Systematically clear fibrous attachments to extend the space. Identification. Local perforators traversing the space. They appear as pulsating pearl-white fibrous columns and are confirmed with the duplex scan. Circumferential dissection. Free 0.5 to 1 centimeter of the perforator from surrounding fatty or fibrous tissue is dissected using a Maryland dissector. Ligation and division. Apply titanium or hemula clips, 2 proximal and 1 distal, and divide the perforator or utilize any energy device like ligashore for clip-free division. Closure. Systematically survey distal to the proximal. Usually 3 to 8 perforators are found. Deflate tourniquet to check hemostasis. Close fascia. Apply 4-layer compression. Technical considerations and efficacy. Wound complications. Open perforator ligation carries wound complication and infection rates as high as 25% due to poor tissue perfusion around the venous ulcers. SEPS reduces this rate to less than 5%. Concomitant procedures. SEPS is rarely performed in isolation. It is usually combined with great or small saphenous vein intervention such as endovenous laser ablation or the radiofrequency ablation or high ligation and stripping to address the global hemodynamics of the limb. Ulcer healing. Clinical register indicate that combining superficial ablation with SEPS yields complete healing of chronic venous ulcers in roughly 80 to 90% of the cases, with significantly lower ulcer recurrence rates compared to superficial treatment alone when severe perforator disease is present. Advantages of SEPS over open Linton procedure. Small incision, lower wound infection rates, less post-operative pain, better cosmetic outcome, shorter hospital stay, faster recovery, reduced wound breakdown are the advantages. Complications of the procedure. Intraoperative complications, bleeding or hematoma formation, injury to the perforator vessels, injury to deep veins which happens rarely, nerve injury especially saphenous or the sural nerve, difficulty in identifying perforators, carbon dioxide insufflation related complications like subcutaneous emphysema and the gas embolism, which is rare but a serious complication. The early postoperative complications: wound infection, port site hematoma, seroma, postoperative pain, leg edema, deep vein thrombosis, and pulmonary embolism, which occurs rarely. Late complications: persistent or recurrent perforator incompetence, recurrence of the varicose vein, delayed or non-healing venous ulcer, ulcer recurrence, chronic pain or paresthesia due to nerve injury, skin pigmentation or scarring less commonly than the open surgery. That's all about SEPS. If you feel it is lengthy, you can cut short the pathophysiology, etc. as you feel like. I hope, I don't think we'll remember whatever we read. So for 10 marks, how much you can write as per your writing speed, decide on that, and how much you can recollect, you can add to it and write the question. Thank you.